Hey, what's happening, Meg? Thanks for coming on today.
Thank you. Thanks for having me. I'm excited to be here.
Yes, I am too. We're going to have a fun conversation. Before we do that, can you just give a quick overview of your origin story and how you got to being where you are today?
Yeah, absolutely. So I am a chiropractic physician. I studied undergrad at High Point University, where I also played soccer. And so I've always been athletic mindset. Sometimes my athleticism didn't always show up the way I wanted it to, but I still have love for sports and activity. I continued my education at National University of Health Sciences, where I pursued chiropractic and acupuncture, oriental medicine basis. And then I actually, during my clinicals of chiropractic school, my probably second patient came in with botulism. And so she had chronic diagnosis of botulism. And she came in for, she really didn't know. She's like, can chiropractic help with this? Can acupuncture? And I was like, no, no, no. This is a systemic condition that my philosophy of chiropractic, which we'll jump into shortly, but doesn't align with that kind of support for the health. And so that really triggered me to pursue a master's degree while in my clinicals for my doctorate, and that is in human nutrition and functional medicine. And so I did those concurrently and graduated 2016 with my doctorate and 2017 with my master's. And we'll talk about here a bit. Hopefully, I want to tell you about scope of practice of chiropractic and how some people utilize it, some people don't. I use every single piece of my scope of practice, and that includes phlebotomy and lab testing and everything that can really identify internal sources of pain and musculoskeletal dysfunction as well. And so that's what I do.
Let's jump into this wide scope of practice. And first, I want to call out that the main reason you are here is because you do not fit the traditional mold, in my opinion, of what a chiropractor. I think you, like you said, you lean into every aspect of it, but you also look at it functionally and holistically. So how about we first set the stage and saying, hey, from your perspective, here's kind of what the blanket perception is of most, or the field of chiropractic, excuse me.
So the philosophy, or really the birth of chiropractic, came from really the late 1800s, early 1900s. Chiropractic, by definition, means by hand. And so, what that looks like from kind of the origin is how can someone, chiropractic physician, manipulate joints, specifically of the spine, to influence the nervous system. And so, from that philosophy, you have a very divided profession. And so you have doctors who still utilize that as their basis of care. And so, for example, there are different styles of techniques and approaches to chiropractic and how the chiropractic adjustment is delivered. And there are hundreds of different techniques, one being Nuka. Nuka is a really interesting it's not even a technique. It's a lifestyle. It's a philosophy in itself that lives within, and it's for upper cervical chiropractic. And those practitioners only adjust upper cervical because they want to influence the nervous system and the brainstem simply by moving the joints of the upper cervical spine. And so, in their philosophy, if they move that, you will see a change of the nervous system that could influence digestion, that can influence migraines, that could influence the foot foundation biomechanics. So therefore, plantar fasciitis could be treated by adjusting the upper cervicals only. And so the philosophy of chiropractic really stems from moving a spinal joint to influence the nervous system in simple terms, right? That's like the sentence that our origin has originated. However, this has really transformed over the years. I would say very much in the last 20 years. Everyone has their own kind of ideas or perspectives of why that has happened. I feel from just the shifting of manual therapy as a treatment or as a thing, osteopathic medicine, osteopathy, really has a foundation similar from the core, and that is adjusting the skeletal system. You want to use the word manipulation or whatever terminology you want to use. But I think it was in it's like 1980s, they started seeing like, oh, osteopathy, let's move more mainstream. 1990s came along, then we were in 2014, and MDs and DOs can sit for the same boards. They can both go to each other's residencies. So now you have a profession that had a similar foundation of, hey, how can we influence the joints in maybe a more allopathic supportive way, being osteopathic medicine. And then this shift, DOs are surgeons, DOs are anesthesiologists, OBGYNs, and they are really, really specializing and prescribing, which is a blessing. They're doing so much innovation in healthcare, hand in hand with their MD colleagues. Well, then once again, we have this gap of, I like to sometimes categorize myself with physical therapists, with chiropractic, those who use our hands, those who look at restoring joint function on a conservative level, and then a big gap to our allopathic colleagues. And I think the DO profession was actually one that we were hoping would be a bridge. And then as scope of practice and as the necessity for having more doctors in hospital settings shifted, we saw this bridge kind of like, ooh, and the gap became bigger. And so that would be my observation or my opinion of like, now why is chiropractic physicians stepping into their scope of practice? Why is that happening? And I think it has really transitioned because there's a necessity there. And with our education differing from those of physical therapists and those of allopathic physicians, we have the ability to say, hey, let's look at your hydration state. Let's look at your supplements. Let's look at your nutrition. Let's draw blood. Let's do imaging within our office because we can take x-rays in our office. We have that within our scope. And let's see how we can get this functioning in a pain-free state.
I'm jealous of all the extra things you get to do in part of your scope of practice, things I can't do as a physical therapist. From your perspective, like I heard you say, hey, you kind of lump yourself into the field of physical therapy at times. Like from your perspective and what your education background is, how did the two professions, two industries cross paths but are different?
Yeah, absolutely. I would say the difference is, and I can't speak to what you are exposed to in school, so if I might be misspeaking in that, so please correct me, but we have botanical medicine, we have pharmacology, we have microbiology, and so we are getting exposed to how does Lyme disease mimic, how does it create joint pain? And so because of that exposure, the difference of how we can approach care could include systemic inflammatory conditions that drive pain, that drive dysfunction. Someone who might be diagnosed on a quick palpation with sacroiliitis, that could be, yes, where if we don't have a blood test of HLA-B27 in front of us, that might be a quick side belt strengthen, which would help. However, what's the root cause of the sacroiliitis? And so I think that there are providers who are leaning into that, and there are providers who have nothing, they don't want anything to do with that. And so the ability is there within the scope, whether people want to step inside of it. And unfortunately, there are some gaps in knowledge from practitioner to practitioner. And so maybe they aren't thinking there. But I think that is something that might be a little different compared to the physical therapist that I've come in contact with, where I would say the similarities are we both know how to use our hands. And that's a blessing. So many practitioners, they don't want to touch people. They don't want to trust their touch. And we are superheroes with touch. And that's a really cool thing. And I'm really proud of that. And I'm proud of physical therapists who also lean into it. I know that it is within the scope of practice for physical therapists to manipulate the spine to joints. And I would encourage them to get even more opportunities for those reps, because I think that's an opportunity for them to really help people. Those who may not necessarily want to go to a chiropractor, physical therapist, you guys have incredible skill sets similar, but maybe the reps might be less. We have numbers that we have to hit in our clinics of spinal manipulations. I mean, our reps are just typically higher from that standpoint. And that's what makes a practitioner better practice. And so, and then I would say therapists within their education have a lot more exercise programming than we do. And so that's the blessing of stability and the strength component of rehabbing someone that chiropractors don't get in their schooling. Can we go on and find continuing education? Yes, just as other practitioners, but most of us don't.
Now, and I think that's where probably our crossover is. You and I can both use our hands. We both can kind of speak that language. But then when it comes to a more medical model, I believe you're much better than that than I am. And then when it comes to the movement and performance side of things, I think that's where I'm able to support you within your practicing. So before we jump into some more interesting topics that you and I really want to dive deep in, I really want to hit home on maybe just debunking briefly or highlighting what some of the common misconceptions of the chiropractor is and why those aren't.
Yeah. Well, some are true, probably. So we'll talk about all the things. But so again, I would say that there are more misconceptions about chiropractors as individuals than chiropractic care as a whole. Because if you look again at kind of the philosophy of chiropractic, I would assume most people think of chiropractic, and thank you to TikTok for also miking up those cracks for us. Thank you. Oh, whether I don't know if that's good or bad for our profession, not something I like to do. However, there's a thought of, okay, if I go to a chiropractor, I'm going to have a forceful movement of a joint that will produce sound. That would be what I think the public might assume happens. And that's probably true in a lot of situations. What the public might not know is that a good chiropractor, so this is the difference between individuals who are chiropractic, working with integrity, versus perhaps a profession as a whole, there should be a neurological physical exam. If someone's going to crack any part of your body or create movement, or, I mean, even work, if someone's going to put a squat, if you're going to have squat rack, you probably should see if that they have other functions to their body before you throw weight on their back. I would, it's kind of that same thing. You should take their blood pressure before you prescribe a blood pressure medication. The same thing should occur in a chiropractic office. And I think the biggest conversation about chiropractic is that neck adjustments cause strokes and create arterial damage. And any force to any dysfunctional tissue can cause damage. Apply that to any part of the body. If you have a broken toe and I say, oh, if I just distract this joint because it's jammed, but it's also kind of broken, I'm going to injure the toe more. So if there's damage present and you put force into it, it's going to create more damage. To avoid that is a physician who is being a diagnostician. They are taking their blood pressure. If someone has a horrible, horrible migraine, why are they having a horrible migraine? Could there already be, tissue integrity damaged here, especially when it comes to blood flow, arterial? There's also a lot of red flags that come with that. What medications are patients on? What is their hypermobility state? And this is where, if I see a hypermobile patient, we're thinking an internal disorder, EDS, we're thinking they're just weak. Where's Adam? Adam, take this patient off my hands. Their hypermobility is out of control. They do not need more mobility. They do not need that. And a lot of mid-cervicals are hypermobile. And so that would be a really bad thing to do. So again, is it a myth? No, it's a understanding that you need to find a chiropractor who knows what they're doing. I think that would be one of the things. And understanding that everyone's different. I think that would be important. The other thing I'll say is, especially in a sports clinic, right? So I work in I have a integrative medical practice here in Scottsdale. And so how I care for people here looks a little different than when I'm in a training room. And so the one thing that I'll add to that is I've had a healthy athlete on the table, right? Maintenance care, maybe, and we're the day before a game. And they'll say, oh, I don't really want to be adjusted or needled today because I don't want to be sore for tomorrow's game. So a myth or misconception where I think some teams might be hesitant to, and I've heard this through, I've had some MLB interactions that they're like, oh, I really want a chiropractor in the training room, but they like to refer out, and which I respect that, but they don't want to be sore after. That comes down to, is the chiropractic physician adjusting his or her treatment appropriately to be effective without causing soreness, right? And so a misconception about chiropractic again, and my challenge to that would be, is your chiropractor making the necessary adjustments of care, knowing the schedule, knowing what the goals are today? And so I would say that is one that I see a little bit more kind of in the training room versus like the public eye.
You mentioned the training room and you mentioned the integrative practice that you're running in Scottsdale. I think that ties in nicely to kind of asking the question, like, what is your approach when it comes to manual therapy and it comes to some of those treatment plans? So let's dive in here kind of on some of the X's and O's and ask the question, like, how do you approach manual therapy within the plan of care?
Yeah. And so I would say my approach differs a little bit from the office to the training room. Here, I'm the only practitioner with my hands on the patient, right? In the training room, I have the opportunity to co-treat with so many different practitioners, which is awesome. And so I like personally, I'll speak to kind of in my clinic, and I like to approach the tissue per layer. I like to identify if we're working with acute dysfunction, chronic dysfunction tissue looks very different, and how the nervous system communicates with acute tissue versus chronic tissue is very different. And so, I mean, we can do like a little flashback here to Dr. Merkin, the rice, which has been, if anyone knows, Dr. Merkin came out with rest, ice compression, elevation. He has retracted that 2014, 2012 to not ice. And that is because of acute changes to chronic changes of tissue and the timing of healing and how that tissue, certain inflammation is absolutely necessary. So with that being said, when you approach manual therapy, knowing where you are in the timeline to support the natural healing properties and not interfering with it, because that you can do all the right things, but doing it at the wrong time, if that makes sense. And so you're not helping the tissue in that sense. So with that being said, then I also like to consider the inflammation state of the tissue. Is it locally inflamed? Is it a referral pattern of, we're talking pain right now, but the dysfunction, you can also talk about like joint mobility in that sense too. But the majority of my patients do walk in with pain. And so those are the considerations I have right from the history taking. You're like, okay, what date was this? When did this happen? You now kind of have an outline of your head of where that tissue is. And is anything communicating with it? If it's chronic, you're like, okay, this thing is just like accepted. It's sad, dysfunctional state. We have to wake it up. And so after considering that, I'll be more mindful of the joint, the fascia, the muscle restrictions, knowing that these are influenced by the nervous system, right? So our nerves tell our muscles to respond. And so kind of leaning into that, there was a really good literature review of fascial innervation. It was published in 2022, and it identifies that joint capsules and ligaments that have changed in some way. So surgery, injury, trauma of any sort that can contribute to ongoing stability, leading to repeated injuries, instability, inflammation, and pain. And that is fascia, right? And so the other thing it mentioned is that, this was fascinating to me, was that it can be observed that the fascia share innervation with other structures. And so we often, I mean, in school, especially in cadaver lab, you're seeing, oh, this nerve supplies the tract. Well, you also have highly innervated fascia that we have cut away that we didn't even get to talk about too much in our cadaver lab. Hopefully now we're better in school. This was 12 years ago. So I would hope that we're seeing it better in those in school now. But all of the nerve endings that are feeding the fascia, they have offshoots that are also innervating those other structures. So now we have a point which could cause a convergence of sensory inputs and amplify the pain. So, right, if someone's having knee pain, are you looking at the muscles, ligaments, tendons, fascia above and below the joint? So when we talk about manual therapy, yes, I can adjust a knee joint. What have I done for function or pain if you don't address the structures associated with that? And that is, we know that because of the nervous system, which is really cool.
You've used the word adjustment, manipulation, mobilization a few times in reference to joint. And I'm curious this question. I'm going to throw another modality in there that you also alluded to earlier. Acupuncture, manipulation, mobilization, and then let's, for lack of a better term, soft tissue mobilization, right? Those kind of four categories. Mm-hmm. How would you explain the difference to what those are? And how are you integrating within the manual therapy approach?
So once I identify kind of that thought process of tissue, I personally like manual therapy. So per all my definitions are ICD-10, shout out to insurance billing, because that is kind of the basis. When I think of, if I'm writing a medical note, if I'm communicating with an attorney who's doing a car accident case, if I have to communicate with a surgeon, I want us to be in a physical, same conversation. So by chiropractic world definition, manual therapy, I think it's the same code for PT, 97140, but we interpret that technique as something done with our hands that increases active pain-free range of motion and extensibility of myofascial tissue. How we interpret that is tissue, not bone. So what would that look like? My style of care, I incorporate scraping, PNF, cupping. I'll use my hands for, just trigger point releases. And then, although you can't code it this way, but dry needling will impact extensibility of myofascial tissue as well. And so when I think of manual therapy, I'm very much thinking of the myofascial tissue. And majority of chiropractors are also thinking that way, who practice similar to me, because we have a different definition of manipulation adjustment. We have utilized the word manipulation, I think, more than ever before, because we are communicating with physical therapists that now have manipulation under their scope. Because you can do grade 5 manips, correct? So
Correct. Yep.
In the world of chiropractic, we are familiar with that verbiage, grade 1, 2, 3, 4, 5. We do not use that, but we will say it because we are over here speaking our own chiropractic language that no one understands, which has gotten us not very far in integrative healthcare settings, right? So I feel like we have morphed our verbiage to fit in a little bit better, but the reality is a chiropractic adjustment is directly influencing a bone or joint complex. So technique doesn't so much matter in that case, because again, back to coding, we have one code, and that is moving a spinal segment. And then we have a code moving an extremity segment. It doesn't matter how we do it. And so the word manipulation, thrust, adjustment is not really descriptive. It's just, we moved a joint. Pretty straightforward.
I appreciate you just going through your thought process and sharing that, because I know it provides me a little bit more color, and also just showing how these relationships can work together between PT, Chiro, and also recognizing that they are different yet the same within certain scopes as well.
Yeah. And I think the difference in that category is the amount of ways that we are educated to influence that joint. Using different tools, we have activators, which are, I don't know, this is recorded, but I have mine here. This is an activator. So this creates very high velocity, it's speed. It's very, very, very fast, very low amplitude. And so, which that's an HVLA adjustment, that's a thrust. However, hands are very different than mechanical means. And so this can go a lot faster than a human hands. And so therefore being very comfortable, very safe, no cracking of joints. That type of tool can manipulate a pubic bone absolutely beautifully. Like it's fantastic, where you're not typically going to do a thrust maneuver into someone's pubic bone. Ribs, this is a very safe, effective way to adjust a rib. Even someone with costochondritis, utilizing a gentle treatment like that and kinesiotaping, stabilizing it right after, is really effective. We have really unique tables that allow us, again, to use speed as opposed to force. Flexion distraction is another way that you can manipulate a joint, bone joint complex without that HVLA. So all of those different styles of techniques can fall into that chiropractic adjustment category.
Perfect. One question I want to ask to wrap up this conversation around manual therapy is, you alluded to earlier in your background how you went and studied acupuncture and Eastern medicine, and then I heard you talk about dry needling at the same time. So could you just briefly touch upon the differences and similarities between the two?
Yeah, absolutely. The similarity is that they both use needles. I believe that is where the similarities end. Their goals of care, they have different, if you're treating pain with acupuncture, the goal might be the same, right? Your both goals are to treat pain. However, the means to treat it looks very different. Dry needling is directly addressing the tissue. By directly, I mean you're placing a needle in or around the tissue, the trigger point, the joint that you're trying to influence. Acupuncture is an ancient Chinese medicine-based approach to healing. This is a foundational medical system from Chinese medicine. And so there's a lot of evidence on it. That's what I also do want to harp on a little bit here, because this conversation of evidence-based medicine and what does that look like? Is there evidence-based to certain chiropractic techniques? No, there are not. Oh, I'm going to get in trouble for saying that, but there are not. And then others, like manipulating fascia, the research on that is profound. It's present, it's evidence-based, it's well done. Chiropractic adjustments done well and appropriately based on evidence is there. Acupuncture is the same. It has been over 2,000 years. And so time has been the best evidence for this field. And the really unique thing about it that I don't think people know is that with acupuncture, we are placing the needles to stimulate nerve-rich areas of the skin in order to influence tissues, glands, organs, and various functions of the body. So where these nerve-rich areas of the skin, those are along meridians. And so the word meridian, it refers to the major longitudinal blood vessel of the body. And so it's really unique because how they define or how they treat, if you will, is by influencing or stimulating these nerve-rich areas, which are the acupuncture points. And by doing that, you are along those meridians, you're influencing the flow of qi. And so qi is blood, nutrients, oxygen of the body per definition of Chinese medicine. And so we have a total of 12 principal meridians. And so you can influence those many, many different ways. And so I absolutely love acupuncture. I use it most in my office for pregnancy. And so breech presentation, 67% resolution of turning baby, which is amazing statistics. And ECVs is around 68 to 71%, which is done by an OBGYN. And so to have less, I would say, aggressive or less invasive opportunity with acupuncture is a really incredible opportunity for those with breech. You can do natural inductions with acupuncture. I work with a lot of IVF, men and women, to prepare for that entire journey, and it's really effective. I also like to use acupuncture for anxiety and depression.
There's the concept of meridians. I've always enjoyed hearing and learning more about it, because I feel like every time I ask this question around acupuncture and Eastern medicine, I learned something new about meridians. And as you were describing it, it felt very similar to two other popular systems thinking approaches when we talk about kind of like the interconnectedness of the system. And one of them is, the Thomas Myers fascial trains.
Yes.
And then you also have Luigi Stecco's work of the Stecco points across the body. So really curious, have you noticed, one, if you're familiar with those, please speak on. If not, we can disregard. But really curious, like, how do the meridians, if you've seen meridians, correlate or have shared similar pathways within the fascial trains and then within the Stecco points of Luigi Stecco's work?
Yeah, so actually there's quite an alignment. I am familiar with both. And if you're familiar, I worked for Dr. Ben Fergus out of school, who is the founder of Grip Approach. And he utilized a lot of those points and has a good grasp on reflexology as well. And so I learned a lot from him in regards to manipulating the Stecco points. And a lot of times where those are looking, they're convergent points. And so I think that is, at the end of the day, the biggest similarity, and something to make a point of is where the body needs to find a fulcrum, where the body needs to move, from a strong fascial convergent point. There's going to be a lot of nerve endings there because it's requiring a lot of neuromuscular activity. and control. And so very fascinating how those do align in some ways. But I would say that as manual therapists, we like to, not all of us, some of us like to go into the point of pain, or like, okay, we're having shoulder dysfunction. Let's look at the neck. Let's look at the scap. Let's look at the thoracic spine. Like, you're kind of in the region. Acupuncture meridians do not function in that way. For example, bladder 67 is a point on the lateral pinky toes. And those are the points you stimulate to encourage the energy chi of the uterus to warm up, to create that energy that baby's like, oh, that's right, my head needs to be down, And so no one, someone wouldn't wake up and be like, okay, the uterus is located near the belly button, but we're going to be at the pinky toes today, where you're going to see more and more people looking at those fascial trains and identifying, okay, plantar fasciitis could have a relationship with TMJ, where I really appreciate that about kind of identifying those fascial lines, which might correlate a little closer to some of the acupuncture points, if you will. But the philosophies are very different.
I agree. The philosophies are very different. It was just as you were describing it, and as I've seen, I've kind of like looked at all three side by side. Like, okay, you got the fascia, you got the meridians, you got the stucco points, and you just kind of just like take away and you recognize, wow, they all kind of converge. Like you said, like converging in a similar, let's call it region or a similar point when you talk about increased sensitivity, increased convergence of muscle attachments, tendon attachments, ligament attachments, integration of fascial trains at a singular point. I think there's just a lot of interconnectedness there. So I just appreciate just sharing the perspective.
Which then really comes back to the nervous system and identifying that is such a big piece that is everything, really, to tissue. So I think we so often want to feel something and be like, oh, if I just crack, for lack of a better word, if I just adjust C2, this will be great. It's like, well, what is the nervous system telling us that's restricting that joint? So different way to look at it.
There's so much more I want to jump in with you, but I know you have a patient coming in soon, so we'll hit pause here. We didn't even get to jump into PEMF or I know PEMF's your new favorite thing. How about we'll take 30-second, we'll give a little teaser, and then we'll have to maybe do like an add-on. What is PEMF briefly?
So, excuse me, PEMF is Pulsed Electromagnetic Field therapy. As you know, it's one of my favorite treatment options for the right person. It's designed to positively influence the behavior of our human biofield. So remember, the human biofield, natural conductor of electricity. And so therefore we generate our own magnetic field. So by introducing magnetic energy into the body, we can re-energize low energy cells to improve cellular function. And so that's going to increase, we're recovering faster, we're reducing pain. FDA recognizes PEMF technology for non-union bone fractures of the lumbar spine, anxiety and depression, glioblastoma. And so unbelievable piece of technology when done appropriately and when it's the right technology. Because unfortunately, I think there are some on the market that might be over-promising, under-delivering.
I think that's fair with a lot of technology. The other one that comes to mind, like infrared therapy or red light therapy, there's a lot of products on the market that don't actually touch the right wavelengths or intensities that you need to hit relative to what we know is meaningful. So, hey, thank you so much for hopping on before you had this client today. I really appreciate it. We will definitely have to reconnect and maybe take a deeper dive strictly on probably PEMF, and because I think there's a lot of power there that I've learned from you, and also I don't think many people truly understand what it is and how it can be beneficial. So thank you so much for hopping on. Last thing I want to do is just, if people are in the Scottsdale area, Phoenix area, or just anyone regionally just wants to get in touch with you, what's the best way to?
Yeah, you can email me, Dr. Byrne at acacianaturalmedicine.com. And feel free to contact me. I'd love to help and support.
Perfect. Well, thanks for coming on today, Meg.
Thank you.